welcome everyone. What I'm going to do today is just sort of open the session with a little bit of a review of what the eye surface profiler can tell us clinically, and then what it can tell us from a laboratory perspective or a study perspective. You know, oftentimes when we look at the ESP system, we forget that it is a very effective corneal topographer as well as a scleral topographer. That is, we can get very accurate axial, tangential, and elevation display maps. And not only are those maps accurate, but they're also pretty extensive, covering the cornea pretty much limbus to limbus. So that's another wonderful feature of the design. But for many of us, especially those of us involved in scleral lenses, where we have directed most of our research is not in the cornea, but really in the shape of the sclera. What we wanted to find out, or what we as clinicians need to find out, is the symmetry of the sclera. That is, are there spots on that sclera higher or lower? And very importantly, the amount of toricity in the sclera. Because surprisingly, there's not a very strong correlation to the amount of toricity in the cornea versus what we see in the sclera. It's much, much greater in the sclera than it is in the cornea. Now that was really brought to light in this particular study done by Marcus Ritzman, a thesis that he had prepared and performed at our university in the United States, Pacific University. What Marcus did is he took 40 individuals with normal eyes that were free of any pinguicula, pterygia, and went in and did corneal mapping and scleral mapping. These are the results of the data on the right eyes, and these the left. Now the numbers aren't important. What is important is the fact that he identified that the nasal and temporal sides of the sclera along the horizontal meridian were very asymmetric. And we can see it here in this diagram. What we see is a top line in red. And what that is, it's the shape of the sclera along the horizontal and vertical meridians. And you can see on the temporal side, it is fairly low, and on the nasal side, it's fairly high. So the sclera is surprisingly asymmetric along the horizontal meridian, but very symmetric along the vertical meridian. So that's what we see here at chords of 17, 15, and 13 millimeters. One of the other very important and striking features of these data is the fact that the asymmetry, this height differential between the nasal and temporal sides, dramatically increases as we increase the chord that is being measured. That is, there's very little asymmetry here at 13 millimeters. However, at 17, it dramatically increases. Now, that's data on the right eye. Here is the data on the left eye. And as you can see, a very, very similar distribution of the height of the sclera, being significantly higher on the nasal side versus the temporal side. Now, what does that all mean to us clinically? It means when you have this kind of human asymmetry to the sclera when you apply any scleral lens, regardless of the manufacturer. When you apply that scleral lens to the eye, it is going to hit first at the area of greatest elevation. And that elevation is always going to be on the nasal side. And we can see here too that the data will show us that the superior portion is higher than the inferior. So we'll notice our scleral lenses all ride slightly temporal and slightly down. It's just related to the height differentials in the sclera. Now, why is this incredible asymmetry taking place? Well, we think it has to do with the position or the insertion of the extraocular muscles. With the medial rectus muscle being inserted only 5 millimeters from the limbus, we're curious as to whether or not that is playing a role in creating that differential nasal versus temporal side of the cornea. Now this brings up an exciting area we need to investigate down the road, and that is asymmetric scleral lenses. That is putting a different angle, tangent angle on the nasal versus temporal sides of the eye, so as to avoid this thinning of fluorescein ever present on that nasal side of the eye. Now, here are the actual physical numbers of that height differential, nasal versus temporal. How high a differential is there? Well, you can see, as we mentioned before, at the 13 millimeter chord, that is not very significant, 340 microns. But as we go to bigger and bigger diameter lenses and get up to 17 millimeter chord, we now see that that differential is fairly significant, nasal versus temporal side of the eye. The beauty of the eye surface profiler is it can identify this very quickly. This red line provides a mean sagittal height along that horizontal meridian, but the actual height differential can be seen with this measurement versus this measurement. Now that is the height differential along the horizontal meridian. Now let's switch over to the vertical meridian and see if this symmetry is still the same. Well, what we see here is that these numbers are much closer to one another, and that there really isn't a big difference between the height of the superior versus inferior portions of the sclera. The superior is indeed higher than the inferior, but not by a dramatic amount. Now remember, we're looking at averages here of 40 normal eyes. There are going to be always exceptions to the rule. And yes, we have seen patients that have a very symmetrical sclera. It's incredibly rare. They're probably not from this planet, but nonetheless, they're out there in practice. Now, the things I take away from this asymmetry in the sclera is, number one, it has helped me so much to better understand why scleral lenses have this tendency to decenter, why they get pushed over to the temporal side and slightly down. Now, it's easy to explain some of that downward movement due to lid pressure and watermelon seed effect and all of those other gravitational forces, yes, those are all playing a role. But we can pin a little bit of this inferior displacement to the shape of the sclera. Now, the other thing this has really helped me explain to the students is to why toric soft lenses may not position where we originally want them to go. We want that marker to position at 6 o'clock, indicating that the cylinder axis is at the position labeled on the foil pack. But we see here, when we put it on a sclera with a significant amount of toricity, that is going to affect the physical position of the lens. This is something we can't control. It is controlled by factors beyond the manufacturer, beyond you and me. It is the sclera dictating where that lens is ultimately going to land. So it is a wonderful tool for me in explaining to the students why these malalignments should take place. But perhaps the greatest thing that I personally have learned from the eye surface profiler is the amount of toricity that is present in the sclera. You see, in those 40 eyes, those 40 patients or 80 eyes that we measured, what we found was that the average amount of scleral toricity was around 4 diopters, 0.80 millimeters. That is the average amount of toricity. Now, these were individuals, most of them wearing spherical soft lenses with little or no corneal toricity. There seems to be a very weak link, if any at all, between the amount of corneal toricity and the amount of scleral toricity. When the two do align, I've always wondered, is it just random? Because we do see that in our lower astigmats, this rather significant amount of discrepancy between the two meridians. So suffice it to say that there's a significant amount of toricity in the cornea or in the sclera, and this builds a very strong story for putting toricity into the back of our scleral lenses. Let's take a look at this particular patient. It's pretty easy to see the height differential between the two primary meridians, and now we're going to put on a scleral lens that has a height differential in just the fitting portion of the scleral portion, and you're going to see as I spin that around, we're going to wait just a second, and if you pay attention to this area right here, you're going to see that spinning around and spinning around fairly quickly and getting back into its position. Just as a saddle that's placed on a horse, you spin it around and it just drops into place. The same thing is true with the sclera. Now, let's take a look at this particular patient with what we might refer to as against the rule scleral toricity. Easy to see the color differential horizontally versus vertically, and now when we place the toric lens on this particular patient, we could see here the markers lining up at 90 degrees, and now when I reach in and spin it around to the 180, we can see here pretty quickly it begins its malalignment or its orientation back to its normal resting position. Now, what are the advantages of this? Well, number one, I believe by putting toricity into the back of the scleral lens, we can now take the weight of the contact lens, instead of distributing it all along one meridian, we can more evenly take that weight, pressure, bearing of the lens and distribute it more equally around the sclera. I think that's probably its greatest advantage. The other advantage, of course, is that if you need any residual cylinder correction due to some lenticular cylinder component, you automatically now have a way to consistently align that contact lens without the need for further ballasting. Now, all of this would not have been possible without the incredible work of Marcus. His work in this area has been nothing short of Herculean. He has done an incredible job with this particular project, and we all, as an eye care community, need to thank him for this incredible contribution. And I need to thank the people at Eaglet for the instrument that has provided us this incredible amount of insight. And remember this, that we have evolved in the past 30 years from keratometry to photokeratoscopy to video keratography to composite corneal topography. And what it has ultimately done is led us to this room here, where we have now taken it one step even further to get both corneal and scleral shape analysis. Thank you very much.